Johns Hopkins University has a pancreas cancer screening program. Welcome back to the channel. A pancreas cancer screening program. That was news to me because there's no screening test I'm aware of for pancreas cancer. We've got mammography for breast cancer. We've got CT screening for lung cancer. We've got colonoscopy, sigmoidoscopy, FOBT, FIT. We've got PSA testing. Many of these are screening programs that have randomized controlled trials. Mammography, many. Colonoscopy, at least one. Sigmoidoscopy, many. FOBT, several. PSA, a couple. Many of these are disputed. I think the NLST and lung cancer screening is a terrible screening program that lacks survival benefits and makes many people patients. I think PSA is a terrible screening program. I think mammography is terrible. Some I think are pretty decent. I think flexible sigmoidoscopy is great, wonderful, saves lives, clear in meta-analysis, really wonderful. Johns Hopkins wants to have a new screening program. They take people with high risk of pancreas cancer. They have some familial or genomic mutation, and maybe they're also not just all the people with the mutation, but a subset of those people who are the worried people who are plugged into medicine. And they have this clinic where they follow these people and they screen them for pancreas cancer. So you're thinking, obviously, they randomize the people to screening and no screening, and they follow them for many decades and see, does screening actually improve outcomes? Well, that would be the smart thing to do. That would be the honorable thing to do. That would be what an IRB should have made them do, but they don't do that. They actually have no control arm. They just screen everybody in their clinic. And they report those results in JAMA Oncology. The title of the paper is Pancreas Cancer Surveillance and Survival of High-Risk Individuals, July 3rd, 2024, JAMA Oncology. I write on my Substack that the worst part of modern medicine is taking healthy people who are fine, who feel and look well, and subjecting them to anxiety-provoking testing and making them patients without knowing you actually benefit them. And that's the problem with this paper. They will, at the end of this paper, they've got no clue that anything they did makes these people better off, and that to me is disgraceful, to take that Johns Hopkins brand and create this clinic, and I suspect the clinic has making money from the scans and maybe even making money from donations because people are worried about going to donate to this program, and they're not even trying to generate credible evidence. That to me is the biggest problem in medicine. So let's take a look at this paper. It's on my Substack now, Vinay Prasad's Observations and Thoughts. You should definitely subscribe there because I talk about more things than I talk about on this channel. The paper says they took 1,731 high-risk individuals who were at high risk of pancreas cancer for whatever reason, and they followed them in their clinic between 1998 and 2021, and over that time period, 26 were diagnosed with pancreas cancer, and this is a report of what happened to those 26 individuals. Well, I've got a lot of questions, but the first question that came to my mind was, wait, you said 1,700, what did you say, 1,700 and, what did you say, 1,700 and then 26 pancreas cancer? I did a little back of the envelope calculation. You got a 23-year, your clinic was open for 23 years, 98 to 2021. You got 26 pancreas cancers you found in 1,700 people. You did all these scans. What's the rate of pancreas cancer you're finding? And it looks like 1.5%. 1.5% of the people in this clinic had a pancreas cancer found. And then my first thought was, well, this is a high-risk clinic, so these are the people who are going to have pancreas cancer. These are the people who got something to worry about. So what's the risk of pancreas cancer in the general population, like a general person who wouldn't be eligible for your clinic? What's their risk? I looked it up, and actually I was a little surprised. The lifetime risk of pancreas cancer is 1 in 56 in men, 1 in 60 in women. That's 1.8% and 1.6%. So this is slightly different, okay? This clinic it doesn't exactly tell me the average age of enrollment in the Hopkins clinic, but I'm guessing based on age of diagnosis and time till diagnosis, it's probably in the late 50s or early 60s. And they follow them for, it doesn't tell me how many years, but maybe 10 years of follow-up, and they get a 1.5% risk of pancreas cancer. But the risk in the general population in lifetime, which is mostly, of course, pushed at the end of life from 50 to death, is 1.8%. What's my point? I do believe it's possible that their clinic has a slightly higher pancreas cancer risk than the general public, because this is not exactly an apples-to-apples comparison. But it's not that much different, is it? It's actually in the same ballpark. I really worry that this is not a high-risk pancreas cancer clinic, but a worried well pancreas cancer clinic. So that's the first problem. They're getting about the same rate. Are they really bringing in high-risk people, or are they just bringing in people who they did the wallet biopsy and they qualified on the wallet biopsy to enroll in the clinic, which means they got the cash to pay for this clinic. All right. First failure. Are they really high risk? They could have been honest, actually, and provided like the rate of pancreas cancer per person year followed and compared that to the general population and age adjusted that. They could have been honest and provided that, but of course they didn't. So maybe I'll write a letter to the editor asking for that, but I have a lot of other things to ask for. The next thing to ask for is, oh, all that 1,700 people who got this screening program, they get serial scans. By the way, back to the first point. The pancreas cancer risk should be higher just because you're doing more scans. Actually, you're going to get some diagnoses that you otherwise wouldn't make. So it's supposed to be higher just because of more imaging. End of story, irrespective of the population rate. And it should be way higher because it's a high-risk group. For instance, Angelina Jolie's breast cancer mutation gave her a 50% lifetime risk of breast cancer. Now we're talking about 1.5, 1.8. There's something fishy here. Okay, second point. They take these people, and then they scan them with EUS, which means they stick the big tube down the throat, and they go look with an ultrasound. They do MRI of the pancreas, and they do all these blah, 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 unpleasant scans, in my opinion. And they find all this stuff, and they follow them. Well, how many people you find something in? How many people get a follow-up scan? How many people get a biopsy? How many people had bleeding on the biopsy? How many people had sepsis after the biopsy? How many people were hospitalized after a biopsy? They don't report anything for all these people except the 26 they diagnosed cancer in. That to me is a failure of the journal. Make them tell us the harms to all the people in whom there wasn't pancreas cancer. How many false scares? How many needle biopsies? What the hell have you been doing in your Island of Dr. Moreau clinic? What have you been doing? Okay, you tell me about the 26. Now, of the 26 people who have pancreas cancer, 7 had it metastatic on presentation. It had already spread to the liver or the lung or something like that. That is a cancer why did you find that cancer? How can you help somebody with metastatic cancer already? 1, no surgery is curative for metastatic pancreas cancer. It's a not incurable condition. 2, if you had not found it then, you would have found it metastatic a little bit later. So you're giving them the diagnosis a lot sooner than you otherwise would, but you're not curing anybody. 3, there's no evidence with pancreas cancer treatments that early treatment versus delayed treatment in the metastatic setting confers a survival advantage. Certainly not in this pre-asymptomatic setting. So 26% of people, I just think, cannot possibly benefit from this diagnosis. It can only add chemotherapy to their life. It may worsen their quality of life. It may even shorten their life from excessive chemotherapy. We have no clue. It's not a randomized study. I'm highly skeptical that any of these 7 people with metastatic disease benefit from this test. Mammography, of course, is not trying to find metastatic breast cancer. It's trying to find local breast cancer. That ratio that 1 in 4 people with pancreas cancer found are already metastatic just speaks to how bad the biology of pancreas cancer is and how foolhardy it is to engage in a screening program for this disease that the moment it's visible in the target organ, 1 in 4 chance it's already spread, okay? It speaks to how foolhardy their whole clinic is. Then, they take the 26 people and they make this stupid Kaplan-Meier plot where they show their survival and they compare it against SEER-matched people, so people in the community who were matched by age and stage with these people, and then they show we have a much better overall survival. Well, duh, you have lead time bias. You've got tons of lead time bias. You don't know how much lead time bias you got. Of course you got better survival. You've made a diagnosis years before you otherwise would have made it, and you're measuring survival from the moment of diagnosis. These people could be dying on the exact same day. They're going to die in 2027, 2029, 2031, but you're diagnosing them in 2024 rather than in 2026 when they would have presented with symptoms. You're adding 2 years of lead time, and you're giving them that label for longer in their life, and you don't know what kind of a survival comparison is this. They do some sensitivity analyses to correct for lead time. Those are inadequate, and I detail well in my essay. Next point, these are not comparable people. The covariates can never be adjusted for because the type of person to come to the Johns Hopkins clinic for the worried people with pancreas cancer is not the average person with pancreas cancer. They're socioeconomically better off. I'm sure they're much more likely to be donors and things of this nature. These are different people. How can you even compare these people? It's foolhardy to even try. And yet they do, and then they claim there's a survival benefit. That's laughable. David Russler Germain writes, quote, "To me, the biggest flaw is that to be identified as high risk for pancreatic ductal adenocarcinoma and be part of such a surveillance program makes you super different than the average age-sex matched patient. How could they possibly compare them to a non-randomized cohort?" And that's what I thought, and that's what any, I think, sensible person would think. Terrible. Doesn't prove anything at all. Could all be lead time bias. Their survival could be worse than if you hadn't diagnosed it, to be honest. It could be a survival decrement. And then the sensitivity analysis is just terrible. You don't know how much lead time you have. You can't correct for something you don't know. 12 months of lead time, I wish. I bet it's more than that. The authors make a brazen and unsupported statement at the end of the paper. A randomized clinical trial comparing surveillance to no surveillance in high-risk individuals is not feasible, end quote. That's incorrect. It is feasible. If you were able to isolate high-risk individuals with really high 10% lifetime, 20% lifetime risk of pancreas cancer, you could do a randomized study. For some strange reason, you're getting a 1.5% diagnosis rate of pancreas cancer in your clinic. Wonder why. And you're claiming you can't do a randomized study. You can always do a randomized study. You certainly shouldn't be doing what you're doing. They also write, quote, artificial intelligence is gaining momentum, end quote. Okay, shut up about AI. I'm not going to help you from this. Okay. AI, first you have to have the I to have the AI. Okay. I'm critical of this paper. You know, somebody said to me after I wrote this thing, they're like, you're so harsh on these researchers. I should be harsh on them. When you go into medicine, you swear an oath to do what's right for people and to make and to take care of people and do what's best. You're taking healthy people, you're doing all this stuff, you're making them patients. Are you ignorant to the entire history of screening? Screening is known to take healthy people and make them patients without making them better off. The only way to know you're not making the same mistake as all the people that came before us in medicine is to randomize. You don't even do that. And then you have the audacity, the chutzpah, to produce this terrible matched analysis that's clearly wrong, clearly erroneous, and you publish that in a journal and you claim that you have a benefit and you've not told me anything about all the false positives and all the false biopsies. It's terrible. It's terrible. This clinic would not exist if it didn't make money, if it didn't get the donations, if people didn't like this. It would not exist. The IRB should shut this down. It's an unethical clinic. These top hospitals do all this kind of stuff. They have their long COVID clinics. They have their pancreas cancer clinics. They just try to see healthy people as dollar bill signs. Scan them, bring them in, referral, follow-up, scan, money. Do they live longer, live better? I don't know. If randomized trial is not feasible. That's their story. And that to me is the problem with medicine. I don't like it. I don't like it at all. I don't like it at all. It's bad. All right, well, those are my thoughts. The pancreas cancer study. Of course, does the journal actually have any critical appraisal? No. Everyone just goes along with it. But I know it's flawed. David Russler may knows it's flawed. I think many of you can read my essay and you can understand and think about screening principles. You'll know it's flawed. And I think a good test of research acumen is to understand why this is not what we should be doing. Okay, if you like this video, you know what to do. Like, subscribe, comment, leave a message below. I might do one more recording on this thing and then drop these videos in the days to come. Until next time.